This week, my case presentation is on renal calculi. So the patient is a 45-year-old male who presents to the emergency department with acute onset of severe flank pain, hematuria, and nausea. He reports that the pain had suddenly began and has since gotten progressively worse over the past several hours. The pain's localized to his right flank, and he describes it as sharp, intense, and intermittent, and that it also radiates to his lower abdomen and groin. The patient reports acute onset of the severe flank pain. Once again, that it's intermittent and radiates to the groin, which are both classic presentations of renal colic that can be associated with urethral obstruction due to renal calculi. The pain he describes as sharp, colicky, and unbearable. The pain follows a waxing and weaning pattern with episodes of extreme pain followed by short episodes of relief. He also reports gross hematuria or visible blood in the urine. And additionally, he reports nausea and vomiting. The patient, however, denies fever or chills. The patient has no known history of trauma, recent infections, or gastrointestinal disorders or disturbances, making other causes of abdominal pain less likely. He does note, however, that he's experienced similar episodes in the past, with one confirmed case of kidney stones 5 years ago that he required medical intervention for, but no surgical intervention. It passed spontaneously. His past history also includes hypertension, which he manages with hydrochlorothiazide, which is a diuretic that may contribute to hypercalciuria, which is a known risk factor of nephrothiasis. Additionally, he reports a family history of kidney stones, as both his father and older brother have experienced multiple episodes. This suggests a possible genetic predisposition. His dietary habits also include a high intake of animal protein, sodium-rich food, and frequent consumption of oxalate-rich vegetables such as spinach and nuts, which can further increase his risk of calcium oxalate stone formation. He works as a construction worker in a hot climate, which also increases the likelihood of chronic dehydration, which is another risk factor due to the reduced urine output and increased urine concentration. He admits he does not drink enough water, particularly during these long work shifts, and often relies on sugar-sweetened sodas, which also increase his risk of stone formation. On his physical exam, it reveals CBA tenderness on the affected side, palpation or percussion over the costovertebral angle, the area between the lower ribs and the spine, elicits pain, suggesting renal pathology. His vital signs indicate elevated blood pressure and mild tachycardia. On abdominal examination, the abdomen is soft and non-tender with no signs of peritoneal irritation, which can rule out acute abdominal pathologies such as appendicitis, diverticulitis, or bowel obstruction. The absence of guarding, rigidity, or rebound tenderness helps differentiate nephrothiasis from conditions involving intra-abdominal inflammation. Renal stones cause severe visceral pain. They don't typically provoke direct peritoneal irritation unless it's complicated by things such as a rupture or an infection. But no fever is noted, which significantly reduces the likelihood of pyelonephritis, obstructive urosepsis, or another superimposed urinary tract infection. So based on all of this, the diagnosis for this patient is most likely nephrothiasis or renal calculi, also commonly known as kidney stones, with possible urethral obstruction. This conclusion, I based it off of the patient's acute onset of severe flank pain, hematuria, nausea, vomiting, and CBA tenderness, all which are hallmark signs of kidney stones. The colicky nature of the pain, its radiation to the groin, associated urinary symptoms, all strongly suggest the presence of renal calculi that causes urethral irritation or obstruction. Renal calculi typically form due to supersaturation of the urine with stone-forming minerals such as calcium oxalate, uric acid, or struvite. Once formed, these stones remain asymptomatic within the renal pelvis until they dislodge and begin to move down the ureter, which then causes obstruction and can trigger renal colic. The severe intermittent pain that radiates from the flank to the groin is a characteristic feature of urethral stone migration, where the ureter undergoes vigorous peristaltic contractions in an attempt to expel the stone. The sharp cramping and wave-like patterns arise due to increased intraluminal pressure, irritation of the urethral mucosa, and reflexive smooth muscle spasms. These all further reinforce the diagnosis of obstructive nephrolithiasis. The presence of hematuria, or blood in the urine, further supports it, as stones pass through the narrow urethral lumens and often cause mucosal abrasion, leading to microscopic or gross hematuria. Also, the CBA tenderness on examination is another classic sign pointing to kidney stones, particularly when there are no fever or systemic signs of infection. If infection were present, other differential diagnoses might include pyelonephritis or obstructive pyelonephrosis, and the patient would likely present with a fever and chills and other systemic inflammatory responses to the systems. However, these are absent, so the primary concern remains to be a stone-induced obstruction rather than an infectious process. The patient's elevated blood pressure and tachycardia are likely physiological responses to the intense pain rather than indications of a cardiovascular issue itself. Pain-induced activation of the SNS system can lead to catecholamine release, which results in the transient hypertension and tachycardia. Given all these findings, the most likely scenario is symptomatic renal calculi causing partial or complete urethral obstruction. The severity of the obstruction is what's going to determine further management, where small stones less than 5 millimeters are more likely to pass spontaneously, and large stones may require surgical or medical intervention for removal. In cases that there is complete urethral obstruction, prolonged blockage can lead to hydronephrosis or swelling of the kidneys, renal dysfunction, or secondary infection, which then could escalate into a urological emergency. To confirm the diagnosis, a non-contrast helical CT scan of the abdomen and pelvis is the gold standard for detecting renal calculi. This image would provide detailed information about the stone size, location, and degree of obstruction. If a CT scan is unavailable, a renal ultrasound can be performed, especially in pregnant patients, although it is less sensitive for detecting small urethral stones and may only pick up larger ones. Additional tests can include urinalysis to assess for hematuria, crystals, or infection, serum creatinine in blood, urea nitrogen, or BUN, to evaluate for renal function impairment due to that obstruction and make sure the kidneys are still functioning properly. Also, a 24-hour urine analysis to assess for metabolic risk factors and things they can alter in their lifestyle to prevent future kidney stones, such as hypercalciuria, hyperoxaluria, hypocytaturia, and hyperuricosuriya. Expected results would show hematuria on the urinalysis, possible elevated serum calcium or uric acid levels, and then imaging would obviously show evidence of stones in either the renal pelvis or the urethra. Treatment, once again, depends on the size of the stones and the symptom severity. So small stones less than 5 millimeters may pass spontaneously with increased fluid intake, pain management, and alpha blockers such as tamsulosin to facilitate stone passage. Larger stones greater than 7 millimeters, or those that are causing significant obstruction or infection, may require extracorporeal shock wave lithotripsy, or ESWL, a ureteroscopy with laser lithotripsy, or percutaneous nephrolithotomy. Infected obstructing stones may require urgent decompression with a urethral stent or percutaneous nephrostomy tube to prevent urosepsis. Long-term prevention includes increased fluid intake, dietary modifications, and medications such as thiazide diuretics for hypercalciuria or potassium citrate for hypocituria.